ఇప్పుడు ఇష్టపడ్డారా అయ్యమ్మ? పేషెంట్ బోర్డు మీద రెడీ
Sorry for the delay. There is a problem in connecting the laptop. Good afternoon, Kuchalabu sir.
Sir, good afternoon.
Anything, sir?
No, nothing. Go ahead. Start.
Yeah, just they are connecting, sir. Laptop they are changing.
Okay. No problem. Okay.
BSc Vizag Intensive Care Studies.
Good afternoon. Good afternoon. Myself, Fatih, IDCCM student in Medicover. My moderator is Dr. Sairama ma'am. Okay. Yes, sir. A 63-year-old male came with chief complaint of fever since 4 days, body pain since 4 days, swelling of legs since 2 days, and one episode of black color stool last night. Patient was apparently normal 4 days back, started fever since 4 days, which is sudden in onset of high grade associated with chills and rigors and associated with body pain, not associated with any night sweats. Bilateral both limb lower limb swelling, which is since 2 days, gradual in onset, pitting type associated with abdominal distension. Past 1 episode of black color stool before day night. No history of cold, cough, difficulty in breathing, pain abdomen. No history of facial puffiness, palpitations, reduced urine output. No recent history of travel. With fever, we can it can be fever and malaria, body pains. It can be chikungunya, which is also a high-grade fever with myalgias, and any bacterial infections, severe bacterial infections can also present with high-grade fever, and tropical fevers like scrub typhus and leptospirosis can also present with high-grade fevers in initial febrile phase.
Most common in India.
Malaria. Yes, sir. Malaria. To differentiate, negative, rule out the causes.
Night sweats.
Yes, sir.
Which condition you will say night sweats?
Lymphoma.
15 seconds. Audience section. Laptop.
So the question is fever of 4 days. What could be the differential diagnosis? Fever of 4 days with chills and rigors. So her answer is malaria and chikungunya and
Scrub typhus.
scrub typhus.
And
So conditions associated with night sweats is the second question.
Any malignancies?
The most common cause of night sweats.
Arvind, use mic. Yeah?
Tuberculosis.
So tuberculosis is most commonly associated and it is often seen.
Yes, ma'am.
Okay.
Fever since the first diagnosis will be malaria, and actually malaria we have to classify things like tropical fevers and bacteria.
Yes.
And,
Yes.
tropical malaria, scrub typhus,
Leptospirosis.
and bacteria urinary tract infection.
Chills and
With fever, chills and rigors.
yes.
And any sepsis like pneumonia is less likely, and these are different factors. So urinary tract infection, which is also
Yes.
called important for fever, chills and rigors.
Okay.
So then, malaria is one of the commonest diagnosis of fever with chills and rigors.
Okay.
Malaria, filaria, UTI.
Yes.
Classic answers.
Yes. Yes.
Okay, go ahead, sir.
And coming to the past history, patient has no history of hypertension, diabetes, any thyroid disorders, tuberculosis, bronchial asthma, and allergies. Family history is not significant. Personal history, patient is
Why travel history is important?
he was malaria from endemic areas, so we to just rule out the any travel history or any pneumonias, any viral pneumonias or bacterial pneumonias, followed by like COVID and COVID, SARS-CoV and H1N1 and malaria. These are the fevers which are common in endemic areas. So we have to just take history to rule out that previous like
swelling of both limbs associated with abdominal dysfunction.
Coming to the swelling of both limbs, like it can be cardiac causes and any renal failure or any previous liver failure history should be ruled out in the history set. This patient is having no previous comorbidities presented. Abdominal distension, like, habits and all. Like regarding habits and all, I didn't mention it. Okay. Regarding personal habits, like any alcoholic or not, I didn't mention it, sir. No.
When you are writing something in the presentation,
Pain. Coming to personal history, patient is a farmer by occupation, takes mixed diet, sleep and appetite are normal, bowel and bladder habits are regular. General examination, patient is drowsy, arousable, obeying commands, moderately built and nourished, had bilateral pedal edema, which is spitting type, and there is no pilar, icterus, cyanosis, clubbing, lymphadenopathy, no rash or no petechia over the body. Drowsy, sir. Arousable, obeying commands. Yes, sir. Yeah, E3, V4, and V5 and M6, sir. M6, yes.
In this type of conditions?
Usually in hypoperfusion, we have to cause.
No, DCS. Glasgow Coma Scale is relevant in this type of cases.
Usually, if there are any correctable causes, we have to correct it in them.
It's okay.
Coming to the vitals, which is of low volume, regular. BP is 90/70 millimeters of mercury. Measured in right upper limb supine position. Respiratory rate is 22 breaths per minute, which is thoracoabdominal type. And room air saturation is 90%. Temperature is 100 degrees Fahrenheit. No raised JVP. After placing a Foley's catheter, urine output is 50 to 60 ml per hour.
So what is the pulse pressure in your case? And what is the mean arterial pressure?
20 is the pulse pressure, ma'am. And mean arterial pressure is, I didn't calculate.
Just tell the form.
Systolic, diastolic pressure, but plus 2/3 into the systolic pressure. It's a pulse pressure. Mean arterial pressure.
So how do you define slow?
Shock is a circulatory failure where there is a decrease in oxygen supply and increase in the oxygen demand, causing cellular tissue hypoxia and cellular dysfunction.
What are the numbers which define shock?
Mean arterial pressure less than 65 millimeters of mercury, and systolic, usually systolic blood pressure less than 90. According to the age, in adults it is less than 90 millimeters of mercury with cold peripheries, mottling sign, and low
Lactates?
and increased lactates more than 1.6, and capillary refill time, increased capillary refill time.
So is your patient in shock?
According to the blood pressure, it is borderline lower side, ma'am. Pulse pressure is slightly increased, more than it is 20 years. So
It is not increased.
increased, ma'am. Low pulse pressure. Low pulse pressure, ma'am. Sorry.
So is your patient in shock?
Yes, ma'am. It's patient is having bradycardia from the presentation, sir. 51.
What is the cause of bradycardia?
Patient,
General cause, what are the causes of bradycardia in paper with
usually viral fevers. Viral fevers can patient have bradycardia due to myocardial inflammation, myocarditis or pericarditis. And there in dengue, there will be SA nodal exit block and AV nodal block. And so bradyarrhythmias are common.
What are the most common causes of bradycardia?
One drug induced, if patient is on any beta blocker, and viral infections, viral causes, and sinus bradycardia we see in laborers and athletes. So
What is the relative bradycardia?
Relative.
In typhoid, you have to see.
Yes, sir. Yes, sir. Bradycardia and
What is the relative?
I don't know.
So there is a hypotension, but there is a compulsory invasive heart rate.
Heart.
But in typhoid, there is a
Hypertension.
relative. The heart rate will be on higher side, but the heart rate will be on higher side, but that is not correlated with the shock.
Sure.
So that is the. That is the.
Okay, sir.
Actually, every 1 degree temperature minimum 10 rate should be high.
Yes.
One point is not 1 centigrade.
Okay, sir.
Every
10.
But if it is not correlated with the temperature, then it is on the bright side.
Okay.
Mostly common examination has some.
Yes. And in ER, patient was resuscitated with IV fluid, 1 liter normal saline, and then maintenance fluid of 100 ml per hour was started. It started on NORAD 4 micrograms per hour infusion and oxygen 5. Yes, sir. In ER, patient was resuscitated with 1 liter normal saline, and maintenance fluid of 100 ml per hour was started, and NORAD 4 micrograms per hour infusion started, and oxygen with simple face mask 5 liters per minute was started and shifted to the ICU.
Why you have started not?
As there is hypertension, borderline blood pressure, so started on the NORAD.
So the patient is in shock.
Yes, sir.
What is the lactate?
1 point in ABG it is 1.4, sir.
1.2.
Sir, per minutes. Per minute, sir, sorry. Per minute, per,
What about the peripheries?
peripheries are warm for this patient, sir, actually. Yes, sir.
So what is the differential diagnosis?
Yes, sir.
Peripheries are warm. So what is the differential diagnosis of this shock? The patient is actually in shock.
Sir.
So what is the differential diagnosis for this shock?
Usually in distributive type of shock, the patient will have warm peripheries present in hypotension. Differential diagnosis are septic shock, anaphylaxis, and neurogenic shock. Yes, sir.
What are the 4 types of shock?
Distributive shock, hypovolemic shock, cardiogenic shock, and obstructive shock. Yes. Coming to systemic examination, cardiovascular system, S1, S2 heart sounds are heard, no murmurs, apex beat felt in fourth intercostal space, left fourth intercostal space. Respiratory system, bilateral air entry present with bilateral basal crypts moreover on the right side. For abdomen, slightly distended, no visible masses, pulsations, no distended veins, no scars, no peristalsis, no local rise of temperature, no tenderness, no guarding, unable to palpate spleen and liver, bowel sounds are heard. And coming to central nervous system examination, patient is drowsy, arousable, and obeying commands, and there is no focal neurological deficit.
Okay.
So,
EP 90/70.
And you said it is shock and narrow pulse pressure.
yes.
In which condition you will see narrow pulse pressure? In which condition you will see increased pulse pressure? In shock.
In initial phase of septic shock, there will be compensatory rise in diastolic pressure, sir. So for this compensation will cause narrow pulse pressure, and later in delayed shock, there will be widening of the pulse pressures.
That is a common cause of narrow pulse pressure shock. That is a common cause of wide pulse pressure shock. Example for
Example.
If you look at the types of shock.
Sir. Sir.
Cardiogenic shock,
Yes, sir.
distributive shock, everything.
Yes, sir.
What are these in the cardiac? What are these in the hypovolemic shock? Narrow pulse pressure is the
In hypovolemic shock, we see narrow pulse pressures.
so here narrow pulse.
Yes.
So shock mostly is due to
Volume. Yes.
hypovolemic.
Yes.
So what is the need of starting noradrenaline after giving 1 liter of fluid?
Yes.
So what is the purpose of starting noradrenaline?
Yes. To maintain the peripheral perfusions, organ perfusion, initially we started on noradrenaline.
Due to increasing the
Sir,
to start the purpose you are telling
yes.
to improve the perfusion
Yes, sir.
by increasing
Pressure, sir.
what pressure? What noradrenaline?
Peripheral vascular. Peripheral vascular pressures, vasoconstriction. It causes vasoconstriction.
So vasoconstriction will increase the
Yes, sir. Diastolic pressure. Yes, sir.
yeah.
Yes, sir.
Okay, mean arterial pressure.
Mean arterial pressures.
So here mean arterial pressure is 90/70. What is the mean arterial pressure?
Around 60, around 76.
70, above
Yes, sir.
70.
Above 70.
So what is the need of starting? What is your mean arterial pressure required to maintain the perfusion?
Yes, sir. 65, below 65.
Here already phenotype is 70.
Yes, yes, sir.
Then what is the need of starting noradrenaline?
Yes.
Was perfusion compromised, especially?
Urine output is also fine, sir.
Okay.
Peripheries are
So
also
you want to say it was not, was it compromised or not?
not compromised.
So how could you say that it was not compromised?
What are the numbers you will see?
Mine renal, we'll see the urine output, sir, whether to see the kidney function. In this patient, urine output is,
Yeah.
yes, sir. And brain, patient is drowsy, so there might be some hypoperfusion to the brain circulation. So, and central and skin, then we'll see the skin peripheries cold, calmy, but here the
There is
patient,
measure to see the skin perfusion.
capillary refill time will see,
You
sir.
haven't mentioned, but you
Yes.
talked about it all,
Yes, sir.
but you haven't mentioned capillary refill time in that slide.
Yes.
Anything else?
Mottling will see, sir.
Okay, that is towards the end of the.
Yes. Yes.
So one card
Yes.
You are telling urine output is good
Yes, sir.
and is after mental stroke.
Yes, sir.
So how do you differentiate this? Is it because of shock? If it is shock, then how he is maintaining urine output?
Yes, sir. Yes.
What is the cause of this drowsiness?
Um,
And we definitely answer the question.
Yes.
Before that, is there any other measure of tissue perfusion? Lab measurement.
Lactates. Lactates. Yes, sir.
And that was within normal.
Yes, sir. 1.4.
Okay.
Yes, sir.
So except for CNS factors, your patient is well perfused.
Yes, sir.
Then you have to differentiate or find out what was the reason for this compromised CNS.
Yes, sir.
Right? Yeah. Answer the Sars question. You repeat Sars question.
Advanced.
Audience.
Sir, after starting fluids, there is a drop, which is started on. So that we can continue.
Yeah, good.
So okay, but this is all basic and important.
See, we are trying to guide you.
Yes, sir.
The short is very important. Okay. He's of answer there. Then we can
Other neurological, we can suspect any intracranial hemorrhage or as
despite the
sir.
despite the FID is maintaining,
Yes, sir.
but patient is drowsy,
Hypoglycemia
hypoglycemia,
and
metabolic and alcoholic.
yes, sir. Dyselectrolemias, any dyselectrolemias, and really regarding the brain, if there is any intracranial hemorrhage or issue, any and raised ICP.
We have not diagnosed. We are not a diagnosis, that's okay. But the most common fever, chills and rigors, drowsy, malaria.
Malaria.
Because not your labs are not yet come.
Yes.
You don't know what exactly.
Yes.
that is.
Yes, sir.
Meningitis.
Neurological.
All this thing we have to.
Yes.
So ippatiki differentials lo em we have removed what are the diagnosis and what are you considering?
Yes, sir.
What have you excluded and what are you considering by this point? And the lab before what are you considering so far?
I have a suspicion of tropical fever, excluding malaria, sir. There are no.
Why?
No, sorry, not malaria.
Why did you exclude malaria?
Fever with chills. Yes, sir. Yes. Malaria dengue and scrub typhus, leptospirosis, and patient is also having respiratory hypoxemia. So have a suspicion of any pneumonia, community acquired pneumonia, and meningitis, urinary tract infection, and meningitis. These are my DDs, sir, for this patient.
So you have included the malaria in your video,
Yes, sir. Yes, sir.
not excluded.
Not excluded, sir.
So, in the first part, early part of the case discussion, you can take from top to bottom.
Yes, sir.
From organ you could take the brain, meningitis and bronchitis. Anything can be brain abscess also can be.
Yes, sir.
Come to the lung and brain.
Yes.
Bradycardia is there. Infective endocarditis,
Yes, sir.
we don't know.
Very.
To get the
Yes, sir. Yes.
and abdomen distension is there, SARS, no. Maybe cholecystitis or hepatitis, liver abscess,
Yes.
anything. Urine, liquid bile apparatus,
Mm.
renal abscess, anything can be possible.
Okay, one more question about your examination. Your abdominal findings.
Yes, sir.
You said the slight distance.
Yes, sir.
What do you mean by slight distance?
But in abdomen looked like distended, but they all there is no signs of any shifting dullness for this patient. Like in view of ascites, it's not tense. There is no
There is
tense
no
abdomen.
meaning for slight.
Okay, sir.
Okay, but you don't use those adjectives.
Okay, sir.
So distance and pressure.
Okay, sir.
Yes. Is distended or not distended?
Okay, sir.
Slight for you may not be slight for me.
Okay, sir.
Slight distance. Slight distance.
So you have to write, you have to write like properly.
Okay.
Definition test.
Okay.
Then your inspection.
Okay. Okay.
I accept zero.
Okay. Okay, ma'am.
Whatever you come.
That's it.
Okay, ma'am. This is probable diagnosis is acute febrile illness with upper gastrointestinal tract bleeding and respiratory failures.
How do you confirm upper gastrointestinal?
Melena, one episode of melena is there in the history, sir. So dark color stools usually with upper GI bleed, but there is. Yes, on room air saturation is 90%, sir. 90, sir. Yes, sir. Creatinine 22, sir. 22, sir. Type 1 respiratory failure is a hypoxic respiratory failure. Type 2 is ventilatory failure, where there is increase in PCO2 levels. And sir, failure of oxygenation or
The criteria is that
below hypoxemia.
The type of failure, when you say respiratory failure,
Yes, sir.
can you say which type of failure this is?
Hypoxic respiratory, type 1 respiratory failure.
Are you sure that this is type 1 or could that be type 2 also?
Asking for definition.
Yes, sir.
Yeah, I mean, yeah. Could this be type 2 failure?
in this, we have a ABC.
Yes, sir.
Initial ABC.
Yes, sir. Yes, sir.
You said the hypoxia,
Yes, sir.
rooming 92% SATs.
90, sir.
And
Yes, sir.
this is respiratory failure.
Yes, sir.
Can you exclude type 2 failure based on the information?
Sir. Carbon PCO.
You talked about what? Oxygen part.
Yes, sir.
Do you know about CO2?
CO2 in ABG, it is,
Do you know?
yes, sir.
Do you know?
Up to this part, we don't know.
Till this
Sir.
point,
We
do
don't
not
know. Yes, sir.
So you can only comment whether this is type 1 or not,
Yes, sir.
but you cannot exclude type 2.
Okay,
So
sir.
you can't really say whether it was type 2 or type 1. You can only say respiratory failure.
Okay, sir.
Respiratory failure, 90%. Actually, respiratory failure is the definition of ABC. Definition of respiratory failure is PaO2 less than
60.
KCO2 more than 60. Without ABC, you cannot complete the combination of SpO2 and KCO2. So you should not use the term also.
Okay,
You
sir.
can say it's hypoxia.
Okay, sir.
Because there is roughly less than 90% of SpO2 corresponds to less than 60. So that is the idea. We will take 90 as less than 60 in ABG. But always, if you want to use the term like respiratory failure, we have to have an ABG besides.
Okay.
That's why I asked for definition of respiratory failure, because usually whenever you are using some words, you should be very cautious.
So how do you put it? Go to the previous slide. Now how do you put it?
Acute febrile illness with shock, upper gastrointestinal tract bleeding, and acute respiratory failure.
You can say respiratory distress.
Acute respiratory distress.
To save you from this language, you can use
Respiratory distress.
Gastrointestinal tract.
Can you put the word shock initially? What is the definition of shock, septic shock?
Like the circulatory failure, not able to maintain the perfusion due to increase in oxygen demand, but reduced supply, causing tissue hypoxia and damage.
After fluid registration.
After enough fluid
Once
resuscitation.
after fluid registration, patient has consistent
Yes, sir.
hypotension
Yes, sir.
despite fluid registration.
Yes, sir.
So fluid registration is
Yes, sir.
only attention.
Yes, sir. Yes, sir.
After that, we don't know what is the response.
Yes.
Now it was started.
Still there is hypotension, so we started on NORADs.
The oxygen therapy.
Not adequately resistant. What is the fluid dose as per the sepsis guidelines?
30 ml per kg for in initial 3 hours of presentation.
How much fluid you have given?
Only 1 liter was
Get a
given.
tenth of weight as per weight.
As per his weight, it is under resuscitation.
Not adequate fluid registration.
Yes.
And immediately started RX, okay. So we don't know the next fluid requirement. That patient may improve.
You can do that, sir.
Yes.
Sir, Dr. David and actually dear friends, no, I request you go in the dengue. I think we'll go in. I already
sir.
discussed septic shock and ARDs we discussed. I think you pertaining to the dengue, you go on ask the questions instead of going the ARDs we discussed, hypoxia and the shock also over. I think better you go on questions about the dengue, etiology, pathogenesis, symptoms, how to classification of the, better go in depth of the dengue pertaining to dengue. That will be more useful for the student. Already these classes are over. ARDs is over and the shock is over. That is my request. Okay, thank you.
సార్ కుచిల్ బాబు సార్ మనకు అది థియరీ పార్ట్ లో వస్తుంది మనం ఎగ్జామ్ ఇలాగే అడుగుతారు కదా
No, that is okay. And I questions and one last time questions and they are supposed to keep it. But అంటే మన క్లాస్ టైం అంటే మనం some time ఉంది అసలు మెయిన్ ఇంపార్టెంట్ డెంగ్యూ అయిపోతుంది. All the questions are asked. I was there in all the previous also these same questions are there. And ఏమవుతుందంటే మన టైం అయిపోతుంది అసలు మెయిన్ ఇంపార్టెంట్ వీఆర్ టాకింగ్ అబౌట్ వై దెన్ వి పుట్ ఆన్ డెంగ్యూ ఫీవర్ టుడే ఓన్లీ.
ఓకే సార్
బెటర్ గా ఉంటుంది అంటే ఫర్ స్టూడెంట్స్ దే కెన్ రివైజ్ చేసుకున్నా కూడా దే కెన్ గెట్ మోర్ క్వశ్చన్స్ అబౌట్ ది డెంగ్యూ. No, now the fluid also you can ask in dengue. What is the madam? What is the fluid? How to give the fluid patient? What is the dose? Is it a septic shock and the same fluid management? Is there any difference is there? Dengue.
Sir, in dengue,
On what basis you are, is it due to shock you will give a fluids or any other parameter will tell you how much of fluid should be given?
sir, in dengue, we'll see hematocrit values, and then depending upon that, we'll resuscitate, sir. And
Yeah, how much? You tell me. That is the most important in dengue, not the shock. Even the patient is not in shock, will get depending upon the hematocrit.
hematocrit, sir.
How much? What is the dose of the IV fluids, whether it crystalloid or colloid?
It is initially 6 to 10 ml per kg per hour, sir.
6 to 10 ml, madam.
Yes, sir.
6 to 10 ml, very, very low. What do the guidelines say?
It is compensated shock. It is 60.
The patient, I'll tell you the scenario. The patient PCV is 55.
Yes, sir.
Hematocrit is 50 to 60. Then how much of fluid you'll give per hour? The patient weight is 50 kg. How much of fluid given for the first hour? How much you want to give fluid?
20 up to 20 ml per kg per hour we can give, sir.
Not 20, even up to 50. The guideline says up to 50, even 100 also I read it. Even 50 ml or 100 ml per kg body weight you can give the till the hematocrit. How many times you will, when you will repeat the hematocrit?
Initially after 1 hour of resuscitation, we'll repeat the
No, not 1 hour. Like that, you should be more in depth about the dengue. You should be every 6 hours you should give on resuscitate. 1 hour you cannot reset the patient, hematocrit fall down. You should give a 50 ml per kg body weight after 6 hours, and second hour you go to 40. That is some formula is there. Then you can see after 6 hourly you can see the hematocrit, and the hematocrit should come to what level, and depending upon the fluid, then you should see. That is the fluid balance and fluid management. And is it, can you give any crystalloid or colloid? What type of fluid you want to give it?
crystalloid, sir.
What crystalloid?
Usually normal saline is a choice of
To what,
fluid.
normal saline up to what? How much of fluid can be given? How many liters can be given in normal saline?
Up to if the resuscitation
What is the
is
complication of normal saline? More than 2 liters we give it?
more than, if it is more than 2 liters, then we can give colloid, sir. Still, the patient is requiring more than 2 liters.
No, I don't. Only I don't want colloid. Only crystalloid only. In a normal saline, what will change to another fluid?
Hyperchloremic metabolic acidosis.
Yeah, that one. What is the other type of crystalloids are there to prevent this complication? Emma?
Ringer lactate, sir.
Good. Ringer or another, any new drug, new crystalloids are coming?
Sir, plasmalate or cabilate, sir.
Those are the names, trade names. You're talking about trade names.
Plasmalate.
What is the plasmalate?
Yes, sir.
Okay,
Yes.
thank you. Thank you. Go ahead. Sorry for the moderator.
Yes, sir. Coming to the investigations on the day of admission, complete blood count, hemoglobin is 9.1 and PCV is 25%, with total leukocyte count of 6,800, neutrophils of 68%, and lymphocytes of 28%, monocytes 2%, eosinophils 2%, platelets 19,000, peripheral smear showing thrombocytopenia, LFTs showing slight elevation of ALT and AST, ALT 115 and aspartate transaminase is 135. Alkaline phosphatase is 319 with albumin 2.5, slightly reduced. PT-INR, APTT are a normal limit, and RFT serum creatinine 0.9 and urea 33, and bicarb 30.4. And sodium 134, potassium 3.6, and chloride 98. Dengue IgM, tropical workup, dengue IgM positive, QBC for MP, scrub typhus, and leptospira serology are negative. Into the D-dimers, on the day of admission are 3,499, and ferritin is 354 and complete urine examination is normal. Shall I go to radiology?
Before registration or after registration?
These investigations were sent on in the year from the emergency room. Close.
Which means very low. And patient if they go, patient will be in hemo concentration.
Yes, sir.
Dehydration.
Yes, sir.
So what is the relevance of these two, XP and EC?
If the PCV is on a higher side, then it will tell the volume status of the patient, the dehydration. Whether
Here PCV is very low. What is the importance of this?
bleed, we can suspect any occult bleed inside. And also patient resuscitated outside previously at home. These are these might be the cause. Already he resuscitated. And the other thing is bleeding. Bleeding.
That question probably that provokes me to ask you another question. Then why did you give 1 liter of fluid and the patient was adequately resuscitated at home? His hemoglobin, hemoglobin was 9 and hemoglobin was 25%.
But at presentation,
This kind of questions we should have.
yes.
Because CR condition is treated. Treated and shifted to the IC.
At presentation, we don't know the lab investigations. So initially BP was low. So patient is a little bit drowsy.
You
So
should have told that patient could be chronically anemic, right?
yes.
That would be a simpler explanation so that all these questions.
Yes, sir. Yes.
So could be chronic anemia and then she got the dengue infection.
Yes, sir.
Also in dengue, the upper bleeding is there. The hemoglobin will be. But estimation very high. Is there a reason why the patient is transferred? HC would be 30.
Yes.
Right?
One reason for alkalosis can be this patient maybe not given sir bicep. This electrolyte or smoker. I said COPD, any chronic COPD. Yes.
Is it a real scenario?
Yes, sir. Yes, sir. Yes, sir. This is the ABG room. Rest. Rest.
Swati, your mic is off. You please on your mic. Swati,
Sir.
your mic is off. Okay, good. On.
Okay. ABC, ultrasound abdomen showing mild ascites with moderate splenomegaly and mild right pleural effusion. ECG showing sinus bradycardia and ABG on room air showing pH of 7.42 by PC. Showing compensated respiratory acidosis with compensated metabolic alkalosis is my conclusion of this. Slight elevation of PCO2 with the bicarb 20. Yes, sir. Compensated pH. Sir. Alkalosis. P 7.4. Metabolic alkalosis.
So why is metabolic alkalosis?
Yes.
There was no ultrasound abdomen. Is there anything else that you would ask for or look for? We are submitting complex fever in this patient.
Yes, sir.
For anything in particular?
Organomegaly is
Gallbladder wall.
gallbladder wall. Edema.
See, if everything is regular, it will be more towards a viral infection.
Okay, sir.
It can't be a localized bacterial source of symptom, probably.
Okay, sir. This is the chest X-ray showing blunting of costophrenic angle. By chest X-ray showing blunting of costophrenic angle on the right side with slight haziness on the right side, right lower zone. I said right pleural effusion is there in ultrasound. Mild right pleural effusion. And ECG showing sinus bradycardia. Rate of 49, sir, in ECG. And my final diagnosis is dengue shock syndrome with bleeding manifestation with transaminitis and polyserositis. Coming to the management on day one.
For the dengue, IgM and thrombocytopenia, fever, we have concluded that it is
Dengue. Yes, ma'am.
Dengue shock syndrome is how it is relevant to this case, and how will you define the dengue shock syndrome in this case?
Platelets are
Dengue shock syndrome.
platelets thrombocytopenia is there, sir. Actually, as per less than 1 lakh platelets. This patient is having 19,000 platelets. And bleeding manifestation, spontaneous bleeding manifestation, and circulatory compromise, hypotension. So I'm according to the WHO grading of dengue hemorrhagic fever, it comes under grade 3 of dengue hemorrhagic fever, which is classified as dengue shock syndromes. Grade 3 and grade 4 are classified into dengue shock syndromes.
How many types of dengue?
As per WHO. Updated WHO 2012 guidelines, it is of 3 types, sir. Dengue fever, dengue hemorrhagic fever, and extended dengue syndrome, sir. Expanded dengue syndromes.
When it is included, expanded dengue syndrome.
2012, sir. 12.
What is a positive tourniquet? When do you do that? And how do you do it?
Positive tourniquet test is to see whether there is any capillary breakage, to just see whether capillary breakage due to this thrombocytopenia. We inflate the BP cuff between systolic and diastolic blood pressure. It is mean pressure, pressure, taking the average of both systolic and diastolic pressure, and we'll take the after removing the cuff after 60 seconds. We'll see whether there are any peticulae. If there are more than 20 peticulae per square inch, then we'll consider it as a positive tourniquetis.
So systolic plus diastolic
By 2.
Keep it at that point
Yes,
for 2 minutes.
for 2 minutes. And then
See for
peticulae.
more than 10.
More than 20 is positive.
Maximum how much time you can keep the expected?
It is for
60 seconds, madam is telling.
after removing we'll observe for 60 seconds. It is inflated for 2 minutes. Okay, sir.
You can do it for 2 minutes and see for peticulae.
Okay.
So what does this tourniquet test indicate?
It indicates capillary breakage, ma'am. Fragility.
So this patient says that he has a dengue last year. So still he can have dengue this year.
There is a chance of secondary infection with other serotype than what he got infected priorly. There are chances of secondary dengue.
Okay. So anybody vaccinated or a person who is had dengue can have dengue this year also. How many times can he have?
With the present,
What are the serotypes?
there are 4 serotypes, ma'am, and infection with the one serotype doesn't give any protection for the second serotype. He can be infected with any other 3 serotypes. So
Which is more virulent and which is less virulent?
2 and 4 are more virulent.
2 and
4.
4.
Yes, sir. 2 and 4 are more virulent.
What is the mechanism?
3 and 4 are very rare, sir, but 2 and 4 are more virulent. Sir,
What is the mechanism? Other serotypes.
second.
మా NS అంటున్నాం కదా.
Yes, sir.
NS1, NS2.
Yes, sir.
NS అంటే ఏంటి?
Non-structural protein. It is a surface protein of the virus. And secondary infection, there will be this macrophage activation where
Antibody enhancement.
enhancement will be there, sir.
How many types of immune response? One is antibody. Second,
Autoimmune will be there, sir. Antibody mediated.
antibody mediated one level. Another one.
Complement mediated. Yes, sir.
Another one. Lymphocyte.
Okay, sir.
3 types.
Okay, sir.
Which is more dangerous, primary dengue or secondary?
Secondary dengue is there won't be any neutralization of the antibodies, sir. So antibody virus component form a complex, and they multiply inside the virus, multiply inside the monocytes, which leads to activation of CD4, CD8 complement activation. Monocytes, sir. Yes.
Any relation to duration this antibody testing?
Yeah. Fever 4 days. Yes. Initial. After the second day of the fever, from initial 4 days, there will be positive for non-structural protein 1, sir. And from the fever, IgM can be positive, sir. In fact,
So how do you confirm if somebody is rapid diagnostic test is negative? Is February, he has thrombocytopenia, transaminitis, and polycystitis. NS1, IgM, and IgG are negative. So what do you do?
But the still clinical suspicion is there, so you want to confirm the diagnosis to rule out a negative.
So what are the
So what do you
what are the tests that are available to confirm negative, and what are the confirmatory tests?
direct viral culture we can do, ma'am. And complement fixation, hemagglutination, and plaque-related neutralization test. These are all for seroconversion positive. Whether patient has seroconversion or not, we
These are
can
not the common tests. I want the common tests.
common test. ELISA,
That is important. So
yes, sir.
that will work.
RT clinic, RT PCR we can do, sir. And NS1 rapid antigen, and ELISA we can do. ELISA for antibodies.
That is more specific
Yes, ma'am.
and sensitive.
Yes.
ELISA is the most, even in the government hospitals, it is available.
So actually, in rapid diagnosis test, what we will do, NS1, IgG, IgM, that is a non-ELISA basic test. So if you want to confirm the diagnosis, then still the clinical suspicion is that you have to go for
PCR.
ELISA based NS1, IgG, IgM diagnostic tests. And some you told viral culture in the sometimes CSF, but there is not clinical use. Okay, clinical this is and there is a four-fold viral IgM antibodies on second week of infection.
Okay.
So this is also ELISA.
Which period of infection each one will face peak levels? And this one will be there, then IgM will there, then IgG will there.
In febrile phase, NS1 will be positive, sir. In initial 3 to 4 days, NS1 will be positive, sir. And from day 3, day 4 of illness, IgM will be positive, sir. And if the patient is already priorly infected, then IgG will be positive. In recovery phase, usually we see IgG positive. After not particular, but date and yes.
Correlation with these markers and thrombocytopenia.
Thrombocytopenia usually settles in critical phase of fever infections. When critical phase is from it is usually from the day 5, day 4, day 5 of the illness. When the febrile fever subsides, then patient will have plasma leakage and
The etiology of the thrombocytopenia, Swati? What is the pathogenesis of the thrombocytopenia?
One is viral related bone marrow suppression, attenuation of macrophage activation, sir, in the bone marrow, and another one is antibody related destruction of the platelets, sir, and another one is conjunctive coagulopathy, sir. These three are the mechanisms explaining thrombocytopenia and dengue.
Good. Okay. Thank you.
Period of illness that are reported in the management. What are parameters?
Hematocrit is the answer. And platelets. These two are the. Hematocrit will rise, sir. Yes.
And this patient daily shock syndrome type 3.
Yes, sir.
So how will you manage this case?
So, what is the criteria for you to transfer a patient or decide the patient's where he stays, either in a ward or ICU? What are the warning signs?
Warning signs of dengue are severe abdominal pain and tenderness with persistent vomiting with mucosal bleeds and clinical fluid accumulation signs and liver enlargement more than 2 centimeters with elevated hematocrit and thrombocytopenia.
Not thrombocytopenia.
Yes, sir.
Rapid fall of
Rapid fall of platelets.
rapid fall of platelets.
Yes.
And
And hypotension. Any organ. Yeah, drowsiness, altered sensorium.
shortness of breath. So you have to
Yes, sir.
always like from head to toe, that is better, right?
Yes, sir.
Will not miss anything.
Yes.
Next.
These are the mucosal bleeds. Yes, sir. Yes, sir.
Any red flags when you're seeing the patient or treating the patient, any red flags that there is some information about prognosis.
Prognosis, severe abdominal pain and liver enlargement and transaminases more than 1,000. Raise in transaminases more than 1,000 and any end organ involvement with reduced urine output or an altered sensorium and icterus.
Rapid fall.
Sir.
Rapid fall in thrombocytes.
Yes, sir. Rapid fall in platelets.
Soon after temperature. Okay.
So you have shown that there is mild elevation in liver enzymes, AST and ALT. Can you comment on that?
Usually in dengue, the most common organ involvement is liver, ma'am. So it presents as a transaminitis. It is graded into 4 types, and if the elevation is more than 3 times from the baseline upper normal limit, then it is grade 1 transaminitis. And if it is more than if it is around 3 to 5 times, it is grade 2. 5 to 10 times it is grade 3, and more around more than 20 times increase in from the baseline, it is grade 4 transaminitis. So it tells the prognosis part of the patient. And AST-ALT ratio. Sir? Actually, there is a presentation reference. I got it from like yes, sir. Yes, sir. I'll share the reference, sir.
So that only the dengue.
Yes, sir. Dengue studies.
Studies.
Yes. Yes, sir. Yes, sir.
there is something to.
Probably.
More than 1,000, you mean to say it has a bad name?
Yes, yes, ma'am.
Actually, but they will have grades. Okay, they will have separate grades.
You share that paper.
Yes, yes.
Another warning signs, you said warning signs. What are other warning signs as per the comorbidities or other conditions?
If the patient is immunocompromised state or any comorbidities like diabetes, hypertension, and coronary artery disease, then it decides regarding the place of treatment of the patient with
Pregnancy and pediatrics.
pregnancy and pediatrics also.
Itself is a warning.
Yes, sir.
These are all
Not
the
the
lines.
case of development.
Yes, sir.
So at this juncture, patient is having melanoma platelets of 19,000. I'll go ahead with the transfusion. Do you agree?
Actually,
Transmission figures for platelets.
yes, sir.
In this case,
Patient in this patient, as patient is having bleeding manifestation, so platelets are around 19,000. You can transfuse platelets for this patient. Normally prophylactic, sir. Usually below 50,000 with bleeding manifestation will transfuse the platelets, and if there are no bleeding manifestation, we can wait up to 10,000, below 10,000. If there is below 10,000, then we can give prophylactic platelet transfusion.
what platelets will give?
Apheresis platelets are preferred, sir. Single donor platelets.
Can you differentiate between single donor and
Pooled platelets are from around 4 to 5 donors, and the lifespan will be comparatively reduced in pooled donor platelets, and antigenic and what we say, antigenic specificity will be like next on further transfusions. There are more chances of reactions for already if patient receive random donor platelets, pooled platelets. So as TP, there is less chance as we are giving from the single donor. These are the differences.
Any other complications you will see the platelet transfer?
One is transfusion related lung injury, as with other blood transfusions and all. Febrile reactions, febrile transfusion reactions, and
Why 10,000 we have to them? Like less than 10,000 we have to take it. You can give it 20,000, 30,000. What is the problem if you give it 20,000, 30,000? Why you choose 10,000?
here it is like more in dengue, it is like conjunctive coagulopathy. Though we give blood platelets, there will be like a consumption of the transfused platelets also. So you can wait till 10,000 where we have high risk for bleeding manifestations.
But we can give even 10,000, 30,000 if we give, what is the problem? Why you are waiting up to 10,000?
Conjunctive coagulopathy is the main reason.
We are more worried about the intracranial bleed. So less than 10,000, there is high chance of
Intracranial bleed.
So that's 10,000 is chosen value. And why we are not giving 30,000, 30,000 is should give every transfusions of platelets that they will delay the platelets recovery from bone marrow. So it will actually delay in the process of recovery of platelets. So that's why we need the threshold.
there are many studies and RCTs which have conducted and they have shown that there is no benefit in transfusing the platelets or prophylactic transfusion of platelets.
Yes.
Then no benefit of the things, but now
10,000 by
delay recovery another I'm not very sure. I can check it.
Actually, what the thing is, we delay the one thing is we want to expect it is the natural process of the disease. So they have to recover. You are delaying the process, one thing, and you are exposing them to more allergic reactions and more transfusions. Obviously, you have to monitor more time. The length of stay will be more and recovery time will be more. Everything will obviously it will increase. So we are more worried about the ICD. That's why 10,000 we have chosen. But the thing is, as previously discussed, if there is a rapid decline, you should have a threshold because it is a dangerous sign. If there is a rapid decline in the platelets count,
Low threshold.
and otherwise bleeding manifestations also you can go early. But the thing is, you have to see about the logistics also. These guidelines, when you are readily available, that is okay. But there are many logistics. You have to arrange everything, and you have to arrange the donors and all. That's why most of the physicians they prefer 20,000. And but at least to BD you have to check platelets, and you should know the trend is more important. How rapidly they are falling and all.
We'll discuss.
So how can you check
Please.
We'll check daily twice usually. We'll see for any rapid decline in the platelet count, and said if there are any further bleeding in the tendons, we'll transfer early, or if there is rapid decline below 10,000, then also it is indication for transfusion.
They keep asking you, when will they start increasing in spite of your SPPs, the platelets are low. So the attendants keep asking you, at what point do you have this in your mind that at this juncture the platelets will start increasing? Usually on which day?
On the day, usually platelets start declining after the febrile phase of the illness, and improves at the end of critical phase. Usually it is around day 10. Day 10 of the day 7. Improving. Yes, sir.
What will happen?
In febrile phase, patient will have a high-grade fever and rash and leukopenia, and can also have thrombocytopenia also. In critical phase, this is a phase where there will be vascular endothelial damage and plasma leakage, and patient will present with shock, features of shock, and rise in hematocrit levels, and thrombocytopenia. Critical phase, this comes with critical phase. In recovery phase, there will be reabsorption of all the leaked plasma and recovery of the platelets.
Recovery phase starts from
Days.
from which day recovery phase starts. So we can expect not a
Day. So, day 7 to day 7.
So what you will ask the pathologist to see the papers?
To see whether it is a true thrombocytopenia and
Of the recovery is the
Platelet, yes, sir. Yes, sir. Absolute platelet, platelet, there will be one marker. Giant megakaryocytes, giant platelets. It indicates 72 hours. In further 72 hours, there will be rise in platelet.
Morning platelet count is 40,000. Evening is around 22,000. So I say asking morning 40, evening 20. You are pressurizing you to be platelets. What do you do?
We will wait. 40. 20,000.
Want me to arrange any donor or anything? Because if you ask tomorrow, by 8,000, I cannot arrange.
Yes.
What you will suggest?
We will ask them to arrange a donor for emergency transfusion if required.
How long can you store that?
As a single donor lifespan will be around 5 days. Single donors, SDP 5 days. If it is an RDP, we have to use it within 24 hours usually.
When here the albumin is low, your number is showing us 2.5. I want to transmit that. Your comment.
It is an albumin is like an acute phase reactant in the infections, so it reduces 2 usually we don't transfuse albumin at this level 2.5. If it is below 2.5, then it is an indication for albumin transfusion. If there is a shock not recovering even with fluid resuscitation, if resuscitative fluid is more than 2 liters, then there is an indication of transfusing colloid albumin along with the fluid. This is an indication. If there is overt bleeding not controlled even with resuscitation, and massive bleed not controlling with yes, sir. PTINR INR if it is more than 2, and if there are bleeding manifestations, then we'll transfuse FPC. Yes, sir.
And when you transfuse, when you select whether to transfuse the FFP or cryo?
Regarding fibrinogen levels, we will send, and for hypofibrinogemia, then it is better to transfuse cryoprecipitate. It has more concentrate of fibrinogen and volume. Actually, there will be acquired deficiency, destruction of the von Willebrand factor. There will fibrino 2579 deficiency will.
Adam DS13.
Yes, sir. Adam DS13.
What is the indication of blood transfusion?
Overt bleeding, there is no, if there is hematocrit, according to the hematocrit, there is any fall in hematocrit levels after resuscitation from the baseline level still low, and there is no improvement in the shock and vital parameters, then we should transfer. Sir? According to the transfusion protocol,
What is the role of
15.
dexamethasone in
Corticosteroids.
There is really a role of antibiotics.
what is the role of ceftriaxone in
Left 15. Yes.
We have 20 minutes ultimate. Okay, no problem. Absolutely reasons. Last and more of the separate toxic. Give it that treatment. Is there any role of antibiotics in dengue?
No role of antibiotics, sir. Doxycycline is only having immunomodulatory effect, and it prevents viral replication inside the host cell. That is the only thing we keep doxycycline.
Immunomodulator and reduce the some studies have shown reduce the IL-6
IL-6.
role of PPA. Already, why you started okay.
Sir, proton